Good afternoon, everyone. My name is Shauna James, and I would first like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I want to acknowledge the importance of this land, which we each call home. We do this to reaffirm our commitment and responsibility in improving our understanding of local Indigenous peoples and their cultures. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We recognize and deeply appreciate their historic connection to this place. I want to thank you all for joining us today for Elevate Impact Hub's webinar. For those of you who may not be familiar with the Hub, we are a new division of OCSA. Our aim is to curate and share evidence-informed research and insights about the home and community care sector. I encourage you to explore our website, which has now been posted into the chat. To date, we have over 100 peer-reviewed research studies, reports, and white papers that provide valuable insights into the home and community care sector. We'll be continually adding and hosting additional webinars throughout the year, so please subscribe to our newsletter for updates. I have some quick housekeeping notes before we begin. Your lines have been muted to help reduce extra feedback. However, you can interact through the Q&A and chat functions, and there will be an opportunity for questions following the presentation. Now it's my pleasure to welcome and present today Dr. Emily King. Emily is the Manager of Research at VHA Home HealthCare, where she leads and researches, researches team focused on creating evidence to inform better care for home care clients, create safer teams of care providers, and build toward a more connected healthcare system. Emily's academic background includes a master's and a PhD from the University of Toronto and a bachelor's degree in mechanical engineering from the University of Waterloo. She holds assistant professor status in the Division of Occupational and Environmental Health at the University of Toronto's Dowley Lana School of Public Health. I'm very excited to welcome Emily and to hear your presentation. So Emily, take it away.
Thank you very much. And let me start by sharing my slides. Can you see what you should see?
Not yet. We can't see it yet.
Okay. Sorry, just give me a second then.
There we go.
How about now?
Yep, perfect. Now we can see it.
Okay, thank you everyone for joining us. And my presentation today is about breaking the silence. It's addressing the underreporting of harassment and violence in community care settings. And so today what I'm going to do is primarily share a pair of projects based in the home and community care sector that have paved the way for a more open conversation about violence and harassment that can occur in the community. The first is exploratory to better understand why community-based PSWs choose to share or choose not to share negative experiences that they have while providing care. And then the second is interventional, it's action-oriented. And so we used our improved understanding from the first study as the basis for designing an intervention to shift team culture and encourage more open conversations about workplace violence and harassment. And today I'm able to share findings from VHA's pilot implementation of this approach and key lessons that I hope will be useful to you, to other community-based care organizations interested in opening up conversations amongst their providers about the experiences that people do have in the community, which can include harassment and violence. And so our objectives today, first you'll hear PSW's perspectives on why they are often reluctant to report their experiences of harassment and violence. I will share a multifaceted intervention that did successfully challenge the normalization and underreporting of harassment and violence amongst VHA's home care PSWs through a combination of policy changes, education, novel intake client screening tool, and end of visit reporting. And thirdly, we'll talk about why PSWs chose to minimize, wasn't expecting that, chose to minimize follow-up for over half of the events that they reported, and ways that we can reasonably respect that choice. And fourthly, we'll discuss the potential of enabling digital peer-to-peer sharing of tips for managing challenging client situations. So the work I'm sharing builds on the contributions of many people acknowledged on the left of this slide, and includes work that was done collaboratively amongst the organization shown and funded by my tax and the Government of Ontario, as well as SE Health and VHA Home HealthCare. So in any setting, we know that it is relatively common for healthcare workers to visit or to experience relatively high rates of violence and harassment. Healthcare workers surveyed have over 60% report having experienced some violence or harassment in the past year. There is a long-standing culture in healthcare across institutional and non-institutional settings, which has tended to normalize and tolerate harassment and violence, especially where it's attributed to the client or patient's medical condition. And this feeds a culture of underreporting, with many care providers just believing that violence and harassment are part of the job. They need to deal with it. There's nothing that can be done. And so although it is normalized, the violence does negatively impact the physical and mental health of the exposed healthcare workers, decreases job satisfaction and performance, reduces the quality of patient care, increases the likelihood that they will leave healthcare. And so these are all highly negative things that we would like to avoid. That's in any setting. Now, we're all familiar with the unique challenges of the home and community care settings in particular. And this has providers working in the physical and social context of clients' homes, not in institutions. They're usually working alone, and they usually have limited access to colleagues. So this presents additional challenges for creating visibility and for providing support. Further, we know that before entering a client's home, our care providers in general, and PSWs in particular, often know very little about the context into which they are entering. And so about the setting, about the clients, about the families. They don't necessarily know enough about what to expect. We know that about half of clients, possibly more, have some degree of cognitive impairment, and that this does bring with it some additional risk of responsive behaviors. So about 25 people or 25% of people with dementia may act in a way that can cause physical or emotional harm to their caregivers. Further, we know that the community-based workforce includes many people who are vulnerable in many ways, many workers who are vulnerable in ways. There's a very high fraction of women, racialized workers, workers who are recent immigrants, workers with lower socioeconomic status. And all these factors can make it more difficult for people to advocate for their own safety. So in this context, the first project that I'm going to share was looking specifically at what influences the choices that are made by community-based PSWs to report or to not report negative experiences that they have while providing care. Because if they don't report, generally we don't know that it happened. There's not usually an opportunity to observe. So we are very reliant on what people choose to share. And so the findings that I'll share are based on, they're part of a larger study that was a 1-year mixed methods prospective open cohort study. So this included all PSWs working in selected areas of a designated home and community care organization over the course of a year. The full cohort included 876 PSWs and HSWs, of whom 230 chose to participate in surveys. This group was predominantly female and predominantly white. although there was also representation from about a third workers from visible minority backgrounds. There was extensive engagement with this cohort across the year through team meetings, 3 with each team, that the research team attended. The research team frequently emailed study updates to people in the eligible cohort. People could choose to participate through baseline, weekly, and closing surveys about their experiences. And sometimes there were participant-initiated phone calls and email contact, which helped provide additional context as to what was going on. We will focus here on some findings from brief weekly surveys that took about 3 to 5 minutes to complete that asked about the experience of work that week, including pain and whether it influenced work and whether it was reported, and any abuse, physical, verbal, or sexual, that was experienced during work. It asked did they think it was related to a disease? Did they continue to provide care? Did they choose to report? And is there anything else you want to tell us? And you may think it's strange that I'm including pain and abuse in this presentation, but I'm doing so because a lot of decision-making regarding whether to report pain was very similar to decision-making around whether to report abuse. And so, do people feel they can share? And finally, is there anything else you want to tell us? And the surveys were analyzed thematically by 2 coders, and I'll share with you some of the results of that coding. So the first reason for not reporting is a fear of negative impacts if a PSW chooses to report. And especially the negative impacts people were concerned about were loss of a client if the client's removed from their schedule, loss of hours if a client's removed from their schedule, and loss of income if a client is removed from their schedule. They were also worried about what if that client is replaced with more challenging clients. So it could be worse. And for many, these potential negative impacts were perceived as outweighing the potential benefits of reporting, because they had experienced losses of hours if clients had been removed from their caseload, because they felt, it just needs to be done, and this is the way the work is. And so we can also read into this limited potential, the PSWs perceiving limited potential for change and for improvement. Also, there was the perception that it's just part of the job. PSWs understood their work to be physically and emotionally challenging, which it is. And then there was also this expectation that the experience of work would include some pain or some harassment or some violence. And, you see in the 2 quotations provided here that this is linked to especially clients with cognitive impairment. But people figure that, in some ways parts of it they can shrug off. So, the client has dementia. Always prior to having a shower, she is verbally abusive, refusing to shower. Anyway, after the shower, she's fine. Or I have nothing to say because I understand that clients are confused and agitated sometimes. And this normalization did lead to a feeling that there wasn't really any point in reporting. There was going to be no change, and so there was no value to sharing. Another reason that you could see in the quotes on the previous slide, and we see here as well, is compassion for the clients, especially clients with cognitive impairment, who may not appreciate the impact of their actions, but who still deserve high quality care. And we saw a real commitment from PSWs to continue providing high quality care, even when they felt uncomfortable. We see, I don't want to make him feel bad if I report it. Unfortunately, not reporting and continuing to go back to the same client can lead to getting abused again. And so one PSW drew this connection very directly for us. So when we look at the takeaways for this, what are the reasons for not reporting? Well, and what are the underlying concerns? So I've summarized the reasons for not reporting on the left here, and on the right, we see underlying concerns related to losing control of the situation. What happens next after I report? This is something I was asked in team meetings as well. PSWs are concerned that they'll lose control of the situation, that there will be negative consequences for the client, possibly, and it will affect the client relationship, or it will affect not just their relationship, but the client's care. Um, there are also real scheduling concerns, fear of losing a client, hours, income, receiving more challenging clients. These are scheduling problems. This is concerns about what will happen to my schedule if I report this negative experience, and if the default is to take that client off of my caseload. And so we know that supervisors are key leaders in the community. One of the things I heard very, very strongly underlying these concerns is that schedulers are key leaders as well. And the messages that schedulers send through their responses, through their actions, through how they work on backfilling schedules after somebody has a client removed. This matters too. And so we do need to consider the role of scheduling. There's also the perception that it's just part of the job, so there's no point in reporting. There's a normalization, there's a limited perceived benefit to reporting, and it's just not worth the fuss or the risk. So these were some key concerns that I saw, and they really fed into the design of an intervention to promote greater openness and to encourage people to report. Also feeding into that is we were looking very closely at the RNAO's best practice guidelines on preventing violence, harassment, and bullying against healthcare workers. Looking at a model of behavior that I will share in a moment. And the design of the intervention was also guided by a steering committee that included leadership from best practice, human resources, both on the safety side and the diversity, equity, and inclusion side, operational leadership, supervisors, client partners, and a researcher. We also had a opportunity for consultation with the pilot group, which included a PSW leader as well. And so we built our intervention around this MARS model of individual behavior and results. We're focusing specifically on motivation, ability, role perceptions, and situational factors, and how we could potentially modify those to promote reporting and openness. And so motivation, if people feel that nothing is going to change, there is no motivation to report, however easy or hard it is. If they feel, people have dementia, it's what they do, there may not be anything we can do about that. Role perceptions, it's part of the job. And if I don't visit the client, nobody will. There's also the question of ability. What am I allowed to do if a client is behaving abusively towards me? And then there's situational factors, not knowing that the client has responsive behaviors that they may exhibit and not knowing how to manage those and how to support the client. So the intervention that we designed is quite multifaceted. It consists of policy updates in support of these other three elements. But primarily, we focus on the education, screening, and reporting. And I'll go over some details related to each of these. Initial education, especially targeted a couple of key ideas. How to respond in the moment, so that ability item, and role perception and motivation for reporting. So why reporting is important regardless of a client's medical condition. If we can't let the next person know that this person may exhibit responsive behaviors, if we don't know. On the other hand, if there's a report, if you can say, this is a responsive behavior that this client can exhibit, and this is an effective way of managing it, then, if you're sick and somebody else is sent instead, or if, another worker is sent on a weekend, They will have better information. They'll know what to do if something arises or how to prevent something from arising. So we focused on the value of reporting to team members. We also focused on how supervisors will respond to reports and created a system that leaves the PSWs more in control of that process. Screening. We added some additional screening, and it was very important to us that this occurs before the first client visit is scheduled. So it had to be a brief addition to the coordinator's script at intake that would create an opportunity for a conversation about potential concerns. We looked at a number of pre-existing screening tools. We didn't find any that quite fit the bill, so we developed our own, which I'll share in a moment. On the reporting side, we knew we had to keep it very fast and very simple. And we were asking for a report at the end of every visit. Did something happen? Yes or no? If no, great. If yes, we ask for a little bit more detail. We leave the PSW to indicate whether or not they want supervisory follow-up. Do they request it or do they not? We also ask PSWs to enter a brief description of what happened and how they managed it, because often PSWs may choose not to report because they don't need help. They know they have the training, they have the experience, they have the expertise. They managed it. They've got this. This is an opportunity to recognize that and to ask them to share that technique, that approach with other people who may not know the client as well or who may not have their degree of experience. And so that was done through them entering a brief description, which could then be shared sort of with client preferences through our client record. And finally, the continual collection of this data provided an opportunity to identify patterns, because sometimes the responsive behaviors indicate unmet clinical needs. And we did find a couple of opportunities to follow up on potential unmet needs. They may also sometimes indicate additional opportunities for training if there's somebody who has not yet had a certain kind of training that may help them to manage the kinds of client behaviors that they're seeing and experiencing. So the education involved quite a range of topics. We had basic definitions of verbal aggression, violence, harassment. We shared reasons for reporting, how this could benefit individuals and especially the team. We had an effort to sort of denormalize the workplace violence and harassment. It happens, but in many cases it may not have to, and there may be ways to reduce its occurrence if we know and if we're able to provide support. We covered how to respond in the moment, opportunities to de-escalate, or if necessary, to leave. We provided encouragement to report and addressed common reasons for underreporting. And then training in how to use a new reporting tool that we developed and what to expect after making that report. And this was done through virtual and in-person synchronous sessions that used case-based scenarios to stimulate group discussion and reinforcement of approaches. So the screening questions. The key one that we asked was, are there any anxieties or concerns about having a home care provider visit? And sometimes there are, and sometimes they may not be related to, for example, responsive behaviors. But the input from our steering committee, which included experienced providers, was that this can be a good way to open up that conversation and to provide an opportunity, especially for family, to share if they are worried about having somebody new in the home. Regardless of the concerns raised, we shared that we want to make this go as well as possible. Do you have suggestions to help us make this a better experience? So this is an opportunity for a client-centered conversation about how to support them during the visit. And in the case of responsive behaviors, we could ask, are there any triggers that our providers should be aware of? We also asked a couple of more structured structured questions to identify specific potential risks. And so we asked about whether there were pets in the home to provide an opportunity to remind clients that pets needed to be away during providers' visits, asking about smoking or vaping, and asking about if there's anything else that could be harmful to people coming into the home. And then our end of visit reporting. The core question was just, did any of the following occur during the visit? Violence, harassment, verbal aggression, or workplace incident? Simple yes or no. If no, that's the end of the report. Thank you. If yes, which occurred? How easy was it to manage? Please provide a brief description of the event and strategies that you used that your teammates could find helpful. And then would you like a supervisor to provide further follow-up? And you'll see even under how easy was it to manage, that's a second opportunity to specifically request follow-up. Now, for leaders on the call, I know that one of the questions this raises is, I have a responsibility as a leader if incidents of violence or harassment are reported, I need to follow up. That is one of my obligations. And so what do I do if somebody says, please don't? The first thing is to acknowledge that overly vigorous follow-up, when it's really unwanted, can deter reporting. And so we wanted to create a process where that didn't have to be a burdensome part of the process. And the follow-up could be conducted sufficiently. The offer of additional support could be made through email. So through a brief acknowledgement that this happened, that we take it seriously, and that we are available to provide support. So we were looking at lighter ways of providing that necessary follow-up. Okay, so how did this go when we implemented it? Well, we tried this in a 32-week open cohort pilot with one of our care teams. So that includes supervisor, clinical lead, scheduling coordinators, PSW coaches, and PSWs. We had 69 PSWs who were providing 410 clients with over 55,000 care visits. So it's quite a volume of experience and of data. And the data sources for the evaluation included surveys, end of visit reports, records of attendance from the education, coordinator screening notes, and some key informant interviews. To give you an idea of who was in this group, it was mostly women, predominantly racialized. East and Southeast Asian was the most represented group, 34% South Asian, and then a number of other identities as well. Most people had previous experiences of workplace violence or harassment. The vast majority of them had had some experience of client-to-worker violence or harassment. A quarter had also experienced incidents involving a client's family member. And a third of them shared that they had experienced but not reported harassment. A fifth had experienced but not reported violence. Normally, this was due to the client's medical condition. Okay, so we rolled out the education. We offered 7 synchronous training sessions. So we were able to reach all of the team leaders and 62% of the PSWs. I'm sure many of you have also experienced some of the challenges in having training reach an entire group of community-based PSWs when everybody's geographically dispersed. This can be tricky. And so we realize we now have to offer an asynchronous option, which we hoped we wouldn't have to, but that's the way to reach more people. Screening, we were able to screen most new clients from private homes, a little over half. The lower rate is essentially due to degree of integration into workflow early on, and then some challenges with language barriers later. 7% of the clients who were screened did have some risks identified during the screening process, and so these could be shared appropriately. Screening typically went smoothly. The exception was that there were a few clients with language barriers who were a bit confused by the questions initially, may have been offended or responded aggressively. Coordinators felt that this was fairly manageable, and that they were just careful about how they asked the questions. And in some cases, they may skip a question if they felt that it was likely to go poorly with the client. They did highlight that the screening questions in part 2 were not a good fit for retirement residence clients. And so a different approach is needed when clients are already living in a facility. The reporting had pretty high engagement. This was a separate little survey that people completed on their company issued cell phones. It wasn't part of the regular end of visit reporting. And yet 3/4 of PSWs engaged at least once. Almost half submitted reports for at least a quarter of the opportunities that they had. And the reporting rate, as usual, was initially higher and then stabilized at a lower rate. But that lower rate was 30% of opportunities. So we're getting reports in almost a third of the times we could potentially receive reports, which is quite promising. It suggests a value that people are seeing in engaging. During this time, 21% of our PSWs did report incidents, mostly verbal aggression, but some harassment, violence, or other workplace incidents. Follow-up was requested for a little under half of the incidents. So in almost 60% of the cases, people preferred not to receive follow-up. They were just sharing information about what happened. Of those reports, 78% included some details about what happened, and just over half included client-specific strategies that PSWs were sharing for the benefit of their peers. So I've got a couple of samples here of what that might look like with events that are perceived as easy and challenging to manage. So he has the tendency to touch you inappropriately while assisting him to walk to his bed or the couch. With the help of his private caregiver, we always remind him that his actions are not acceptable and not to do it. This is the approach that PSW takes in managing this client. And then it's a reminder approach again that we see in the next suggestion. I ask him to calm down and I speak softly in a calm manner. So we've got, this is what's working for these individuals at this point. PSWs found this system quick and easy to use. All who reported incidents believed that they were taken seriously, which was an improvement on our baseline. 91% of those who requested follow-up were satisfied or very satisfied with its quality. A couple of people were neutral. And generally, PSWs perceived the reporting as valuable, but requested its integration into the usual workflow. We did see evidence of a shift in culture when we looked at the closing surveys. People expressed greater comfort sharing concerns about how they were treated at work, particularly with incidents related to clients and families. And the one sort of fly in the ointment here is that some PSWs did share that they were still choosing not to report some incidents of harassment and violence. And the reasons were they were confident in how it was managed. They attributed it to a client's medical condition. And in some cases, they wanted to prevent further conflict. So we're not all the way there, but we did see promising signs of a shift and people seeing value in the greater openness. We saw enough value in this that we're moving ahead with expanding and spreading this program within VHA. Generally, the intervention was well received and seemed to be effective in creating that culture change. We saw high engagement, positive feedback, and increased comfort and openness discussing workplace violence and harassment. We saw increased confidence in managing incidents, and that's positive. The end of visit reports provided us with increased visibility into PSW's experiences during care. So without that visibility, we don't know how best to provide support. And so this led to some really helpful conversations. It highlighted some opportunities for intervention as we were able to identify unmet client needs, for example, for improved pain control. And it was perceived as valuable and not burdensome by the PSWs. Now, it was difficult to reach all of our PSWs with the synchronous education, so we've added an asynchronous option. And the screening approach was generally well received, valuable for private homes with some potential risks identified. At this point, it's not the solution for getting additional information about the retirement home clients. So why do we think this worked? I want to share some key messages here. We respected PSW's expertise, and highlighted how it could benefit their colleagues. So people were choosing to report so that their colleagues had better information when they went in to cover a client. They were reporting to inform and support each other, which is different than reporting just so you know what happened to me. PSWs knew what the process would be after they reported, and they remained in control of the degree of follow-up. So nothing was taken out of their hands. There wasn't a risk that they would lose a client and hours and income just because they'd reported a challenge. And leadership is available to provide support, and leadership had greater insight into what was happening. So going back briefly to our objectives, we've heard PSW's perspectives on why they may be reluctant to report their experience of harassment and violence. And a lot of that has to do with fear of negative consequences and losing control of the process. There is also compassion for clients who may not appreciate the impacts of their action and not wanting to lose control of what happens to the clients as a result of reporting either. And there's the perception that it's just part of the job and therefore no point in reporting. And so we were able to emphasize what the point can be to reporting. I have shared our multifaceted intervention. And in terms of an understanding of why PSWs chose to minimize follow-up, they know what they're doing. They're comfortable, they're confident, they feel a situation is handled, and they don't need additional fuss. But it can still be helpful if they report, because if they report, they can share with their colleagues what happened, and they can give their leaders better insight into what's going on with certain clients, to what their experiences are in the community. And sometimes you get multiple people reporting incidents with a single client, and that highlights that there may be something more to it. And that provides an opportunity for additional follow-up, even if it hasn't been requested. And that was well received too. And something that I really liked about the way this rolled out is that we did see the peer-to-peer sharing of tips for managing challenging client situations, so that a PSW who sees a client for the first time has a better idea of what they're coming into and how they can best support the client. If you're interested in trying this approach, we're happy to share any of the materials that I shared that we used during this. As I said, we think this has potential and we're scaling up, and we are hoping that our colleagues at other organizations may also be able to benefit from some of what we've learned here. So please feel free to get in touch. My email is here. There are some references that will be in the deck that you have access to after the webinar recording. And that's it for me. I'll turn it over to Sue.
Thanks, Emily. That was amazing. Such incredible insights. We do have one question, and it is this only for PSWs? Will this also be available, I think maybe applicable for other service providers?
We focused first on PSWs because this is where we perceive the greatest need at our organization. We designed something that we believe would work for others as well, possibly with tweaks. But yes, we are interested in expanding this to our, we have nursing and rehabilitation providers as well, and we're interested in expanding it to them as well. So I think that this will work with other groups, but we haven't tested it yet. If you would like to take a look and see how you can adapt it for other service providers who you work with, as I said, we're happy to share, and we're happy to talk about the decisions that went into design and how those might be modified.
Perfect. I actually have a question as well. Earlier in your presentation, you mentioned that there was the perception that PSWs feel that harassment or violence is part of the job. Did you have any insights into how that perception came about, or any more information about that?
This is something that is very well supported throughout the healthcare literature, is that healthcare providers in general often perceive that some degree of violence and harassment are part of the job. And part of this has to do with compassion for the clients and patients they're seeing and recognizing that they may be seeing people on their most difficult days, that for clients who have cognitive impairment, they may not understand the impact of their actions or have other ways of communicating that there is a problem. But also there has been a culture of self-sacrifice, needing to do sort of whatever is necessary. And in some ways there can be a fatalism that because of these other factors, nothing can change. And I think if you talk to, occupational therapists who focus on behavioral supports, they will absolutely tell you that some of these things can change. There are opportunities to provide environments that are less likely to trigger responsive behaviors. There are opportunities for ways to de-escalate situations and ways to get ahead of some of the issues, but only if they're known. And sometimes there are additional experts who can be brought in to help provide support. So hopefully that answers your question, Sue. Sue, if you're responding, you're on mute.
Oh, sorry about that. Is there data on the satisfaction with resolutions based on the staff that requested follow-up?
Yes, the staff who requested follow-up, this is 91% of them were satisfied or very satisfied with the follow-up they received. The remaining were neutral rather than dissatisfied. And so it seemed like that was the de-identified survey data. So hopefully people felt as ready to share there as they were ever going to be. We also heard in other ways that people did appreciate follow-up when it was provided, but you never know when it's just word of mouth. I think the surveys, the data will go with there.
We have another question from the chat. We're particularly interested in underreporting of racism, microaggressions, and other types of discrimination. Did you get any insights on how often that is part of verbal abuse?
We were not specifically asking people to classify by racism, microaggressions, other forms of discrimination. That was absolutely part of the training. And we've had one of the designers of this intervention was our director of diversity, equity, and inclusion. And so that is a major area of focus for him. He was also the person who delivered the education. And so that was a message that I hope came through in the education, is that these are forms of verbal abuse and ought to be shared, even if it doesn't bother you or if you can brush it off. It's something that we would like to know about because it matters and it shouldn't be happening. And it's something that the next PSW who visits should be forewarned about. So unfortunately, I don't have the breakdown that I think you're asking for, Patricia, but that was intended to be part of it. We did ask that people share.
I think we have time for about one more question. Was there any discussion about financial compensation for the time that goes into reporting incidents for those of us who are paid per visit? I know some of my coworkers are generally discouraged by how much unpaid work we do, and that reporting is just another thing we do not get paid for.
I hear your concern. I hear your concern, and certainly the idea that, that factors into the question of, is it worth it? Is it worth my time? Our approach in this project was to try to make it as fast as possible, so that you could share within 1 to 2 minutes. Our providers did say they found it quick and easy, not burdensome. Some people would just sort of complete the day's reports while waiting for the bus on the way home. It does take a little bit of time. There was not additional compensation provided for it. We were relying on people seeing inherent value in choosing to submit the reports. If there has to be a more extensive conversation, then that does take more time. and then that, ought to be recognized separately.
So Emily, we do have a couple more questions that we're not going to have time to get to. Could I suggest that people who had those questions could perhaps email you directly? Emily, is that possible?
Yeah, I would love to engage over email, or if it makes sense to us to have a conversation, then I'm happy to set up a little bit of time to chat to follow up on remaining questions that you have.
Okay, perfect. And Emily's email address, as we saw, was in the presentation. So thank you, everybody. It was a great conversation.
Thank you, everyone, for coming and listening. It's great to be able to share this work.
Yes, thank you all for joining us today. And I'd just like to give a special thank you to Emily for giving her time and sharing your work. And the recording of this webinar will be posted on the Elevate Impact Hub in the next few days. And just a reminder to complete a very short survey that will pop up at the end of this webinar.